The past decade has seen a dramatic increase in efforts by health systems to address individual health-related social needs. Although screening for social needs and addressing them is important, it could also divert attention from the goal of advancing equity in patient experience and clinical outcomes. I'm Stephen Morrissey, managing editor of the New England Journal of Medicine, and I'm talking with Alicia Fernandez, a professor of medicine at the University of California, San Francisco. Dr. Fernandez has co-authored a perspective article about healthcare equity as part of the journal's series on the fundamentals of medical ethics. Dr. Fernandez, what falls under the category of health-related social needs, and how do those needs affect people's daily lives and their health?
There are many things that can be considered health-related social needs. Some people used to talk about them as the social determinants of health, so that refers to a somewhat different concept. And health-related social needs include things like housing insecurity or absence of housing, food insecurity, inability to pay for utilities, difficulty with achieving transportation for medical visits, and so on. The ones that I mentioned are among the 5 that have been prioritized by the Joint Commission and by CMS, both of whom have been encouraging health systems to screen for these health-related social needs.
And then how have health systems incorporated that screening into their care processes, and what's driven that focus?
I think there's several things that systems are doing, and I think we don't have a clear evidence-based view of what's happening throughout the country. Some systems are asking only about 1 or 2 of these, such as housing. Other systems are going through all 5 that are recommended by the Joint Commission. Some systems are doing this upon admission to the hospital. Others are doing these in primary care. So I think there's really a large variety. What we do know from a recent article is that over 80% of hospitals include at least 1 social needs screening upon admission. As to what is driving this, that's a really complex question. I think that there's several things. One is that there has been appropriate attention to social determinants of health, and increasingly so over the last decade. And what that means is that recognizing that broad ways in which we organize society, structural factors such as income distribution, educational attainment, and so on, influence people's health as well as the quality of healthcare that they receive. So on one level, there's a good recognition about that. And some people, I think, have confused screening for health-related social needs, which occurs on the individual level, with social determinants of health. And health-related social needs is about what happens when people fall through the cracks of the social safety net, which in the United States is far weaker than in other countries. And that's how we end up with so many people with food insecurity or with housing issues. So on one level, it's really important to focus on the broad drivers of health, the social determinants of health. And in many of the European countries, for example, people focus on that by investing a lot more into social services. On another level, it's important to help individuals who have needs, health-related social needs, with those needs. And that's why I think there is also enthusiasm for doing this screening now. Put another way, I think that what drives this is a mixture of some amount of conceptual confusion about what's a social determinant of health and what's a health-related social needs, and a sense that these health-related social needs do impact health outcomes.
You say in your article, though, that this focus on social needs screening raises ethical questions about the best allocation of resources. So why is that the case?
I think that there is a limited amount of energy and appetite within most health systems to focus on healthcare equity. And that, I think, should be the main focus of healthcare systems. Health-related social needs are important. Safety net institutions, such as the one in which I practice, have been screening for them and partnering with community-based organizations to address them. But for many organizations, there is only a limited amount of energy, a limited amount of resources, and we are concerned that this will detract from what we absolutely need to be doing, which is reorganizing the healthcare system to work better for minoritized patients, including the vast majority of minoritized patients who do not have these health-related social needs and yet may obtain suboptimal healthcare and have suboptimal clinical outcomes.
And you say in your article that these healthcare-centric goals, equity in patient experience and clinical outcomes, should be the primary equity-related targets for the healthcare sector. Why have those goals not been a central focus up to this point?
I think that until very recently, there has been no business case or regulatory case for improving health equity. And so systems can say, well, about 70% of all of our patients are meeting hypertension goals, or 80% of our patients are meeting hypertension goals. And they have not been required to stratify their data by race, for example, or similarly, say, for diabetes or for other illnesses. And so there are often people who are tasked within health systems to improve healthcare equity, but generally have few resources or little authority with which to make necessary changes. And just to be clear, health equity is nowhere near a priority for most health systems. So, for example, in most health systems that I'm aware of, there is no health equity component to a CEO dashboard or to a health system dashboard. So saying, how are we doing with hypertensive control among African Americans compared to whites, or diabetes control for Latinos compared to whites, is not part of that leadership vision, which may be more focused on making sure overall quality metrics are reasonable, as well as, of course, more of the day-to-day function of a large health system.
So what types of programs at the healthcare organization level could support more equitable care and outcomes?
I think that in order to focus on healthcare equity, there needs to be three sort of large things. One is the leadership and governance that favors health equity. The other is a reorganization of care in order to support health equity. And third needs to be payment policies and accountability metrics that support health equity. So the one where I think we can do a fair amount is on the reorganization of care. There is, for example, many studies that support improving hypertension care, for example, through the use of registries, through the use of pharmacy visits, home health monitoring, increased visits for patients with low literacy, and so on. And that sort of package of interventions are not, to our knowledge, routinely implemented in most health systems. Similarly, we know that community health workers have been very efficacious in helping Spanish-speaking Latinos with control of their diabetes. There are many RCTs now that have shown that. And yet most health systems have yet to integrate community health workers into their clinical flow. Fortunately, in some places, there is now more funding for programs such as community health workers. And fortunately, some payers are starting to reward equity. So, for example, Blue Cross Blue Shield of Massachusetts is incentivizing for equity. The VA had a pay-for-performance program for reducing inequities in Black hypertension control. Some of the Medicaid programs, such as CalAIMS in California, are now providing flexible funding that can be used to help reorganize care, as well as things such as enhanced care management or flexible dollars to be used for community supports. So we're starting to see some movement among payers to support health equity, but there is a lot that could be done within healthcare systems by reorganizing existing resources that we think has not been done on a national level, though good data on a national level are lacking.
And finally, and you've begun to answer this already with your statements about payment, how could people at the policymaking level encourage a greater emphasis on these efforts to advance healthcare equity?
I think equity needs to be an accountability metric. It needs to be an accountability metric for CEOs, and it needs to be an accountability metric for health systems, much in the same way that we have HEDIS measures for certain types of chronic disease control. We need clearer metrics, which have been developed by several organizations, and we also need that funding that incentivizes those metrics and rewards those metrics. So on the public funding sectors, there's a lot that CMS is doing, and those programs can be expanded to other states. Private payers, such as Blue Cross Blue Shield, the example I gave, can do a pay for performance with equities. And then some people believe that risk adjusting patients, so that patients who have more social needs or more complex medical needs And the health systems that take care of those patients are effectively rewarded for taking care of those patients, as opposed to systems which may encourage cherry picking in a pay-for-performance type approach.
Thank you, Dr. Fernandez.